Bismillah Rahman Rahim. Today we will have case quiz number 74. Case data: 22 years old female. She is working as a marathon runner, complaining of bilateral insufficiency fractures of the femoral head, confirmed by X-ray and MRI. This had not been occurred in association with any increase in the usual training program, and the patient was struggling to return to training after this fracture. She didn't have any past medical history of note and was not on any regular medications. Examination showed mild proximal weakness in the upper and lower limbs, with low body mass index only 17.2 kg per meter square and normal stature. Investigations showed hemoglobin 10.8, mild anemia with low MCV, mean corpuscular volume, which is hypochromic anemia, microcytic hypochromic anemia, alkaline phosphatase 320, which is high, calcium 2.2 millimole, which is low, parathormone within normal 28 picogram per milliliter. Vitamin D3 showed 125 dihydroxy vitamin D3 is low, 7 picogram per milliliter, but 25 hydroxy vitamin D3 is normal, 36 nanogram per milliliter. So, what is the diagnosis? The answer is yes, it is easy. It is osteomalacia. Osteomalacia. So the first possibility here, or the most appropriate, is osteomalacia. But is it the only diagnosis? No. Which underlying causes should be considered also? The low body mass index in this female athlete raises the possibility of the female athlete triad. Further corroboration should be sought in the history, including evidence of amenorrhea, poor dietary habit, and laxative and diuretic use. These are missed part in the history and should be searched for. The presence of the female athlete triad increases the risk of osteoporosis, which would be a possible explanation for the development of insufficiency fracture without any increased loading. Other risk factors of osteoporosis should be identified, and DEXA scanning should be considered. Fractures in the context of proximal muscle weakness raise the possibility of osteomalacia, which is the most appropriate explanation for this case, which can be caused by vitamin D deficiency or parathormone independent defect in the renal handling of the phosphate. Risk factors for vitamin D deficiency include reduced oral intake, decreased sun exposure, malabsorption, severe liver disease, and renal insufficiency. Aging is also associated with significantly reduced 1-alpha hydroxylase activity in the kidney, and some anti-epileptic medications such as phenytoin increase the deactivation of the active metabolite 1,25-dihydroxy vitamin D in the liver, which is not the case here because this is a young female and athlete. Characteristic features include bone pain and tenderness, proximal muscle weakness, and non-fragility fractures. These are the characteristics for osteomalacia. In children, bone deformity occurs resulting in bowing of weight-bearing bone and irregularity at the metaphyseal-epiphyseal junction, which is usually detected at the wrist and costochondral junctions. The latter result in rachitic rosary. Harrison Groove described the indentation of the softened ribs at the insertion of the diaphragm. Rapid growth of the softened skull results in frontal bossing and parietal bone flattening. This is in the children, which is rickets, rather than osteomalacia. Dentation may be also poor. All these is not the case of our case, because our case is a young adult, not a child and not a very old patient. Laboratory investigations in vitamin D deficiency can show low serum calcium and phosphate and elevated alkaline phosphatase and parathermone. In this case, we have only low calcium and elevated alkaline phosphatase, but normal parathermone. Vitamin D ergocalciferol is obtained from the vegetable sources, whereas vitamin D3 cholecalciferol is mainly sensitized in the skin following exposure to ultraviolet light, and can also be derived from food sources such as oily fish and fortified food including milk, juice, and cereals. Most forms of vitamin D are rapidly converted to 25 hydroxy vitamin D in the liver, but only a fraction is activated to 125 dihydroxy vitamin D by the kidneys. Thus, the former is the best marker of body stores of vitamin D. And vitamin D deficiency, 125 dihydroxy vitamin D level, D3 level may be well normal, whereas low 25 hydroxy vitamin D D3 level are diagnostic. Osteomalacia due to altered phosphate homeostasis is rare but gives rise to the same bone histopathology. Causes include the following: excess antacid use, often over several years with phosphate-binding antacids, idiopathic hypophosphatemia or X-linked hypophosphatemic rickets, which is caused by vitamin D resistance and manifests with short stature and rickets in the homozygous male and variable growth and deformity in the females. Early recognition is the key in order to prevent long-term deformity. Fanconi syndrome is associated with a number of congenital and acquired conditions where proximal renal tubular defect result in glucosuria, amino aciduria, phosphaturia, and hypophosphatemia. Laboratory investigations show a very low phosphate and 125 dihydroxy vitamin D D3 level with normal or slightly low calcium and normal or slightly elevated parathermone. 25 hydroxy vitamin D3 are normal. The biochemical abnormalities detected so far in this case fits with the diagnosis of hypophosphatemic osteomalacia, and serum phosphate levels should be checked. So the most probable diagnosis in this particular case is hypophosphatemic osteomalacia. The presence of microcytic anemia also raises the possibility of gastrointestinal malabsorption, which could be associated with celiac disease. This would account for the low BMI, leading to increased risk of osteoporosis rather than osteomalacia. Malabsorption can also result in vitamin D deficiency and osteomalacia, but the normal 25 hydroxy vitamin D3 level may make this unlikely unless vitamin D resistance is present. Further investigations for this case include serum phosphate is 0.48 millimole per liter, creatinine 62, urine analysis normal, urine phosphate increased, and anti-endomysial and anti-tissue trans-glutaminase antibodies are normal. The most likely diagnosis is idiopathic hypophosphatemic osteomalacia, taking all these investigations in consideration, and the treatment depends on the exact underlying cause, but generally include both phosphate and vitamin D supplementation. So, we agreed that the most probable diagnosis here is idiopathic hypophosphatemic osteomalacia, but what are the rare diagnoses should be considered if the patient failed to respond to treatment as expected? If the patient doesn't respond from a biochemical or clinical perspective, a rare phenomenon to suspect is oncogenic associated osteomalacia. The tumor is usually benign and of mesenchymal origin. The mechanism is not completely understood, but it is thought to be mediated by the humoral factor fibroblastic growth factor 23, which deregulate proximal renal tubular phosphate handling, and some improvement can be seen with vitamin D and phosphate supplementation. However, resection of the tumor usually results in cure. And finally, as usual, thank you very much for your attendance, and we will meet you tomorrow with case quiz number 75. Wassalamu alaikum wa rahmatullahi wa barakatuh.